Hi there, and welcome to the next edition of the Academy by Acclivity Health Solutions. And today we're going to talk about the players that make up some of the key roles or play some of the key roles inside of value-based care. We'll talk about them as risk-bearing entities, which are often the ACO or the health plan, the managed care organization, the managed services organization. Those are all the risk-bearing entities. The participants, which are often the groups, the health systems, the networks, and the providers. These could be point of care clinicians that are billable under sort of the traditional rules of reimbursement, or they can be navigators, coordinators, engagement staff that are centralized. So those are the sort of the three big pools of persons that play a part, entities that play a part in the value-based care landscape. So we'll dive in a little bit and talk about who they are in depth. Risk-bearing entities are consistently figuring out how to make use of the premium dollars that they capture from either their actual premium paying members or through delegation by Medicare under Med Advantage, as an example. They actually have benchmarks given to them where they collect and put their arms around the entirety of what's available to them that Medicare is going to essentially pay, and they try to find savings opportunities such they can create gross margin. So risk-bearing entities are well known. You'll see them all across the United States. 1,000 or so of them are ACOs. The lion's share of Med Advantage is really housed under 5 or 6 really big entities, but there are several dozen, maybe 100, 150 Med Advantage plans that are out there. Many of them roll up to big aggregators that you know by name. So that's the risk-bearing entity side. The participant side, think of organizations that are health systems or hospitals or physician groups or networks, IPAs, that come together with the sole intent of trying to build the back office smartly so that they can participate in risk. That's why they're called the participants. They will focus their energies on what we often call Moneyball for medicine. How do I play this new game where reimbursement models are tied to the triple aim originally, which were reduction in cost, higher or equal quality outcomes and patient satisfaction. And now here the quadruple aim physician satisfaction is part of it. So be mindful those participants have the job of being sort of in between the risk-bearing entities as a structure and above the provider, the individual provider, usually MPI level clinicians, but also surrounded by other providers that play the role of engaging the persons between point of care or episodic care. So those are the three big pillars. Let's talk about what they have as responsibilities. So the player one, the risk-bearing entity, that person or that entity has the responsibility of optimizing, managing, and owning the arrangements between Medicare and the participants. They'll often write contracts. They'll often have products under those contracts that look like we're going to pay you more for this service and pay you less for this service. They're incentivizing behaviors across the network. They'll look for poor performing practices and remove them or require them to take consulting to improve them. So their job is always thinking about how do I optimize the network? How do I ensure that I'm meeting the required benchmarks? How do I hold back or withhold if they aren't meeting certain benchmarks? So they're consistently thinking about business, operational management, and measurement. Like that's their core goal. And you'll hear things like medical loss ratio, which is where they're trying to manage how they deliver the total cost of care and achieve benchmarks so that they can create gross margin. The participants often need to understand clinical and operational measurement, like how are they actually thinking about what they work on based upon their populations. So in order to succeed in any of their current or VBC arrangements, or think about moving into potential future VBC arrangements, they're always thinking about attribution. They're thinking about risk stratification and utilization. Like how are these persons typically acquiring care? Are they going to the emergency department for non-emergent care, primary care treatable things? They need to be thinking about modeling under actuarial science. They need to be thinking about health economics. So those are the things that typically happen. This is what we always call Moneyball for medicine. If you've not read the books or seen the Brad Pitt baseball movie, that really was a huge shift from scouting for the major leagues for baseball, which was where instead of looking at a player's physique, his batting stance, his potential, trying to think of like traditional physique, batting stance, throwing mechanics. Like those were the things they would look at because they would think of the durability or the usefulness of a player by their eyes. What they shifted from in Moneyball was that as the lens to look at a player. They shifted from that physique level look to the statistics. How often were they actually getting on base? How often were they getting across home plate for a run? Like those kinds of things became really important. For Moneyball for medicine, instead of having this, I'm going to open my practice, I'm going to, go through my clinical training, get through residency, I'm going to become a person that's hung their shingle and are taking on new patients. And allowing the patients to decide how they consume through episodic care and fee-for-service based practice, you're now switching the lens to say, I'm actually going to look at my whole population and I'm going to decide who gets my attention, because they potentially can be prior to a crisis. They can be a rising risk patient population. They could have bad behaviors about how they, access care. They could have increasing disease burden. They could have new onset diagnoses, like a problem that's worsening. Like those are the things that you can look at in this approach, which allow you to take a more statistical or population level look versus just seeing whoever crosses the transom and gets scheduled in your appointment for your care. So those are big shifts that happen. When you're a provider under those arrangements, again, the Moneyball for medicine applies here because you're really transforming the kinds of care that gets delivered by thinking through what data can I convert to insights from my point of care staff that then can drive them to act in a certain way. What data can I use in my care management teams that can provide insight that can drive a queue of patients that need encounter engagement? Might need medication support because they're not able to refill their meds because they don't have enough money. So like finding community resources to do that work is not your point of care job, but it certainly is your care management and clinical interventionists that are in that navigation role. That's the job they play. So we'll dig deeper in how these players operate in future Academy content. If you need more help or if you want to suggest content, reach out to us at info@acclivityhealth.com. And we'll see you soon on another Acclivity Health Academy session. Take care.